we are going to talk about nodules. So I'm going to describe how to systematically approach nodular diseases, hoping to get to a final diagnosis. Once again, my email is my last name at ufl.edu. All right, so let's start with the basics. So nodules are primary lesions. Remember, we talked about over and over the importance of identifying primary lesions when we are presented with skin cases. Because if we only look at secondary lesions, there are many diseases that look alike. So when you do your physical exam, always look for primary lesions. So nodules are solid lesions that can stand in the dermis, sometimes even the subcutaneous tissue. And so as a clinician, when I see these lesions, the first question is this inflammatory or neoplastic? That is the first thing that we need to establish. So many times, however, nodules will break and you're going to have secondary lesions like ulcers and draining tracts. So when I talked about ulcerative diseases, many of them, were kind of like secondary lesions. So remember, ulcers, if you just look at the ulcers, is not very helpful. Always look for nodules. And actually, that is critical when later on you're going to go ahead and biopsy these cases. So what I'm going to cover is how we're going to rank our differential diagnosis based on history, physical findings, and how we're going to basically decide which diagnostic test to do. This cat here had prototheca. Prototheca is a algal disease that is rare, but is present in tropical climates. So I suppose you have prototheca here as well. This cat had nocardia, right? So these are all ulcerated nodules on the face of cats. So when I'm presented with these cases, it's very important to figure out how these lesions have progressed, how long they've been there, if there is any travel history. There are some infectious diseases that are present in certain areas of the world, or for example, within the U.S., there are some areas of the U.S. that have some fungal infections versus others. I have no idea what it would be your situation here, but I think it's important to know where the animal has been so that you can rank your infectious diseases from most likely to least likely. It's also important to know if the animal is systemically ill or not. There are some infectious diseases in which there is a systemic illness and other ones in which there isn't. And also to see if anybody else is affected. And then when we do the physical exam, we want to notice what the distribution of the lesion is, if it's a disease that is progressing, if it's following the lymphatics or not. So these are all things to kind of keep in mind. And then mentally, I say to myself, okay, first of all, is inflammatory neoplastic. Okay, within the inflammatory, let's say that, and I'm not going to cover neoplastic diseases, right? But for the inflammatory, then the next thing is that infectious or not? And so where I practice, which is very similar climate to what you have here, in my mind, is infection until proven otherwise, okay? Because infections are so common. And then within the infection, I divide bacterial versus fungal or fungus-like oomycetes, okay? And then sterile is a possibility, but I always put it kind of like once I have ruled out infectious diseases. So this is my biased approach just because of where I practice. So what are differential diagnoses? I kind of made a list, and this is all in your notes, so you don't have to write everything down. But basically, I went by categories. So fungal infections. So fungal infections is a long list, from crypto to histo, coccidioides. These are all things that you acquire through inhalation. But you can also have other fungal infections where the port of entry is the skin directly, like sporothrix or the carrion and so on. And so I'm going to talk a little bit about each one of these diseases to see what are the similarities and differences. Now here in this picture, some example. So this is a carrion. Carrion is a name for a nodular infection caused by dermatophytes. So dermatophytes really like keratin and hair. They don't like to be stuck in the dermis. But if dogs kind of stick their nose in a hole in the ground, and so they accidentally inoculate the dermatophyte in the dermatophyte many times dies, but then you have this aggressive inflammatory response, and you have this nice nodule, and on the bridge of the nose is a classic location. So that's an example of fungal infection. But then you can have example like this cat that is basically looks like it could be infectious. It looked like it could be Cryptococcus, but it turned out to be mosquito hypersensitivity, right? So you cannot just look at something and immediately say, I think I know what it is, okay? So it's very important that we are systematic when we approach these cases. Then I made a list of bacterial diseases, starting with common stuff like pyoderma. We talked about superficial, but now this is deep pyoderma, right? Because superficial pyoderma is a pustular disease, but the deep pyoderma, I'm going to have these nodules because I have furunculosis, nodules that will drain, and so I have draining tracts. And then the other example of bacterial infection, I'm going to talk about atypical mycobacteria, which is a form of spreading paniculitis because you're going to have these nodular lesions and draining tracts, okay? So these all examples. And then as examples of non-infectious sterile diseases, again, the mosquito hypersensitivity that we discussed earlier, and then other diseases, like dogs can get this sterile nodular paniculitis. So it's a possibility. Wild cats, when they get paniculitis, is typically an infectious process. Dogs can get paniculitis that is sterile, and we're going to discuss that. So it's a long list, right? So we need to be systematic when we approach these cases. You can have an index of suspicion, but ultimately we need to have a consistent approach. So one thing that can be done is starting with, of course, a surface cytology, if you have something that is open. If it's not, you can do a fine needle aspirate. And sometimes you have some answers, sometimes not. Most of the time, in my experience, you end up needing to biopsy these lesions. And the biopsy, the ideal thing is to actually get a whole nodule. You know, if possible, a lesion that is not ruptured yet, and so that you can do a wedge biopsy, remove the whole nodule, and I typically kind of send some for histopath, where I kind of ask the pathologist to please run some special stains based on my differential diagnosis, and then some I submit for culture. Okay, so the histopath, again, you need to ask special stains or the pathologist will do it for you. When you submit for culture, there are some diseases in which you have very few organisms, like atypical mycobacteria. So it is important to provide, if at all possible, a large sample, because otherwise you may have a negative culture result just because there are very few organisms. And then there are some infections in which you need to have special media, so you need to know what you're going after, because they may not grow in just an irregular aerobic culture. And I'm going to get into that. So my typical standard approach when I submit a nodule for culture, if I don't know anything, I ask for aerobic, anaerobic, mycobacterial, and fungal culture. These are 4 different cultures. Anaerobic, you may kind of remove it if people don't have enough money, but aerobic and mycobacterial are critical if you're looking of anything that has like a paniculitis, okay? And then fungal, depending on your index of suspicion. All right, so let's see some example of bacterial infections. Some you've seen a ton of them, I'm sure, like abscess. Okay, abscess is the simplest thing that you're gonna have that is gonna come to your practice. And so those are easy to diagnose, right? So you kind of like have cats that end up getting in fights, and so they develop this swelling on their face. You need to kind of drain the lesion, put them on antibiotic. That's kind of like an easy one, right? So that should not present a diagnostic challenge, right? And so if cats roam around the neighborhood, you know, maybe they're not neutered, they get in fights, and so that's something. So the abscess is the simplest thing that they can do, but that is also how they could possibly acquire atypical mycobacteria, which we will talk about later. So it's basically animals that fight and have the organisms under their nails. So abscesses is typically not an issue. Amoxicillin, clavulanic acid, establishing a drainage, and so that is kind of like an easy thing to fix. So it should not be a challenge. Many of the cases I end up seeing are the ones that have been treated as an abscess and they did not respond. So it's important for us to have plan B, right? So if you have one that looks like this and you do the basic stuff and they don't respond, what are other possible differential diagnoses? And I'm gonna talk about that in a minute. Now, going down the list of examples for a bacterial type of infection, the pyoderma. So we said the most common organism is Staphylococcus. You may or not also have Pseudomonas, but you can count on the fact that you're going to have Staphylococcus. And I hope that you don't get much antibiotic resistance, but be prepared the fact that I'm sure it's going to happen. And so if you have cases where you have used cephalaxin and it did not respond, don't rule out the possibility that it's bacterial. It may be that you are dealing with methicillin resistance, and so you got to culture these cases so that you don't just guess what antibiotic to use. So these infections are deep, and animals are treated for extended periods of time, so it's more important to know exactly what we're killing and what is the best approach. And some of these lesions can actually become quite ulcerated. Now, examples of localized pyoderma is mesopoderma, right? So you have these dogs that get nodules in the chin, lip area, and they have been treated topically. Maybe with benzoyl peroxide many times because they have been diagnosed as a chin acne, but it turns out to be actually an infection. So what are the things that you can possibly do? We use a lot of mupirocin in the States. I think here maybe you use fusidic acid. You can attempt to treat it topically. Some of these cases may require systemic just because of the severity of even if it's a localized furunculosis, but the topical may not be able to reach these lesions. In my experience, some topical steroids also help to decrease some of the swelling. So these are examples of a localized form of deep pyoderma. So it's the furunculosis. Other example of localized pyoderma or pyoderma-like lesions are nodules on the muzzle or on the bridge of the nose of dogs. So differential diagnosis for that, some we have already discussed them. They can have insect bites, they can have autoimmune disease or other diseases. The first thing to do is cytology, right? So if I'm concerned about fire ant bites, These are eosinophilic lesions. They develop quickly. So the history plus your cytology helps you to decide that that is an allergic condition versus an autoimmune disease where you're going to expect to find neutrophils, possibly acantholytic cells, and so on. So these are just pictures of basically different presentations. So you cannot just make your diagnosis by looking at these cases. You want to start with your cytology, go through your list, and then, do your fungal culture or put them on antibiotic, or depending on what you find in your cytology. So again, it's very important to make your list and go through your list. These are just examples. Then you can have localized deep infection on the feet. We talked about deep pyoderma when we talked about the pododermatitis, right? So these are severe cases. Always rule out the Demodex, always rule out other diseases that can affect the feet, like hookworm, dermatitis in animals that are not routinely dewormed, and maybe they live in a kennel situation, or they walk on ground that is contaminated. And so, but many of them have a deep pyoderma that needs to be treated appropriately for extended periods of time. So you're going to see these cases. And so it's important that you go through your list. This one had Demodex and deep pyoderma, and so you need to properly diagnose them. We already talked about the deep pyoderma on the German Shepherds, so again, these are all examples of nodular bacterial diseases that drain, and so you are left with the secondary lesions of ulcerative draining tracts. You got to be aggressive. I encourage you to culture these cases so that you know exactly what you're dealing with. Many of them have Pseudomonas, but you don't want to use fluoroquinolones indiscriminately unless you know that that's what you need to use. Then there are some breeds of dogs that have been reported in the literature to have predisposition for severe deep pyoderma that may be idiopathic. So the Bull Terrier has been reported in the literature. There are some that basically develop this aggressive deep pyoderma that is very challenging to treat, and actually some of them actually are so bad that people choose to euthanize them. So the long story short is that deep pyoderma can be a challenge, but it's quite common. We need to, anytime we do the cytology, we find neutrophils and macrophages. You may find some eosinophils because you have furunculosis, so you have free hair in the in the dermis, which kind of triggers that kind of allergic response in the body. So you may find some eosinophils, and you may find very few bacteria, but don't let that fool you. It doesn't mean that it's sterile. It just means that the bacteria are deep. So if you're not sure, take a biopsy. Prepare the skin, surgically scrub the skin, take a biopsy, and submit the tissue for culture. Not just swab the surface. Swabbing the surface you're gonna get a lot of bacteria that may not be the true pathogen. Okay? So these animals are on extended courses of antibiotics, so it's very important to pick the right antibiotic and to understand why they're getting this infection. All right, so those are like the run-of-the-mill staphylococcus, right? So now we're moving to a disease that we have not discussed so far, so the mycobacteria. So the mycobacteria that I'm going to talk about is not the TB mycobacteria. I'm talking about fast growers, opportunistic, or atypical mycobacteria. This is what you're going to see we see quite a few, so I suspect you have the same thing here. These cats that have this spreading paniculitis, typically on the ventral abdomen, and they have this non-healing wounds. So I'm going to show you some pictures. Sometimes, the first thing that people notice is that the hair is a bit wet and matted. Once you start clipping them, you realize that the lesions are much more extensive than what they look on the surface. And you can palpate the skin and feel that it's infiltrated. So it looks like feels like lumpy, but then this nodules ruptures, and so you're left with all these ulcerative lesions. So you can see this patient had multiple, right? And so it's a spreading paniculitis. So they kind of moves over time. And so the ventral abdomen is a preferred area for this disease. And so you get these large ulcerative lesions that can become pre-aggressive. It's a paniculitis, so many times early on you have this oily feel to it, but it's a bacterial infection, it's not a sterile disease. And it's almost like what people refer as a flesh-eating bacteria, right? So they kind of like the skin basically falls apart, and then when you start clipping, you realize that it's more and more extensive. It's not just the area where the skin was wet, but you have more and more lesions. It's important that you clip these areas because when you're gonna go and take a biopsy, you wanna take a biopsy of a new nodule. You don't want to biopsy an area that is already ruptured, that has all the secondary stuff. You want to find something fresh, new, that is not ruptured yet. But these lesions are progressive, and as terrible as these cats look like, most of them, they are happy, healthy, eating. You know, it's like there is a disconnect between the severity of their clinical presentation and the fact that they are otherwise seemingly systemically well until they get another type of bacterial infection. Say if they get Pseudomonas on top of that, then they get sick. But they basically develop these lesions. Like you can see this cat, these have not ruptured yet. This is ulcerated. This is, these are all kind of too old lesions that would be of no benefit to biopsy or stick a swab for culture. And I also encourage you not to think that surgery is the answer for these cases. I've seen quite a few where people felt that maybe if they could just cut out the infected tissue, that could be a solution. The point is not, because the infection is much more extensive than what it looks on the surface. Also, these lesions don't heal well after surgery, so they will end up dehiscing, and so you end up having with a larger and larger defect in the skin. But again, the ventral abdomen is kind of like a common area for this disease. So dogs can get atypical mycobacteria as well, and it's typically the result of an infected needle. So the way you get infected with this organism, they are in the environment, they are opportunistic pathogens, and they get inoculated in the skin, either by accident through a dirty needle or through cats fighting because they have it on their nails, okay? So, but in dogs, this infection is not nearly as frequent as it is in cats, at least in my experience. So when you do your cytology, you're going to find neutrophils and macrophages. But you're not going to see the organisms. For one, they're deep. For two, they're very few. For three, they don't stain with diff quick. You need to have special stains to see this organism. So the fact that you just see a pyogranulomatous inflammation with no bacteria does not mean that is a sterile disease. You got to biopsy these cases, and some people do PCR to even just have an answer whether it is an infectious disease or not. But ultimately, in order to treat these cases, you need to have a culture and sensitivity, because this is a family of bacteria. There are many different kinds of atypical mycobacteria, and they may have different sensitivity. So your PCR may just tell you, okay, you have Mycobacteria smegmatis, but it's not going to tell you what antibiotic to use. You can have an educated guess, but again, there is variability in the sensitivity to antibiotics. So I strongly encourage you to take a large tissue sample after you surgically prep the area and submit it to the lab, and ask for a special culture, asking specifically for mycobacterial culture. They will not grow in a regular aerobic culture. On histopathology, what the pathologist is going to describe is these vacuoles in the panniculus. So this, quote, empty spaces. They're surrounded by neutrophils and macrophages. But in these vacuoles, you have the organisms, and you need to have special stains to see them. And hopefully they will run them for you. And you may see them in the draining tracts, but these clear vacuoles are kind of like a characteristic of this disease. So it's a pyogranulomatous spreading panniculitis. And with special stains, you're going to see this filamentous bacteria. But once again, it doesn't tell you what antibiotic you can use to kill them. So many of these are sensitive to fluoroquinolones, but some are, require doxy or other combination of drugs. So I encourage you to have the culture and sensitivity. I also, I'm sure you know this, but I just in case, you do know that Baytril is contraindicated in cats, right? So we did this a lot in the US years ago. We did not know that Baytril can make cats blind, and so I can tell you that 20 years ago I made a lot of cats blind because we were treating them for mycobacteria and they were on Baytril. So there are other fluoroquinolones that have been tested not to be toxic in cats in terms of ocular side effects. So prodofloxacin is one of them. So it's very important to be aware of that. Another infection that looks like mycobacteria is nocardia. Now, these cats are systemically ill. So this is a difference. The mycobacteria cat looks terrible, but is still eating and feeling good. The nocardia cat, in my experience, is typically a sick cat. But clinically, skin-wise, they may look very similar. And they may have different sensitivity to the antibiotics. So once again, it's very important to have your culture and sensitivity. But just looking at them, it's the same. It's basically a panniculitis with all these ulcerative, oozing lesions. They may have it on their feet or on their belly, depending on, but these nodules are a manifestation of a systemic infection. And then what you may see is these grains. So basically this, you may see it clinically, but you may also see it on histopath, where you have this basically accumulation, this conglomerate of bacteria that are surrounded by this aggressive inflammatory response. So this is like a draining tract, and then you have all these grains that you don't see with mycobacteria. Maybe? Okay. We're moving to fungal infections now. So I mentioned that some fungal infections you get infected by inhalation. So cryptoblastohistoblastococcidioides are examples of that. They are crypto is kind of worldwide, but there are some other infections that are kind of more specific to certain parts of the world. For example, for us, coccidioides is more in the western states, so Florida doesn't have that, but we do have Cryptococcus. So when you see nodules with this systemic fungal infection, it's typically a manifestation of disseminated disease. Hardly ever is because the fungal organism has been inoculated directly into the skin. But you can have other types of infection in which the organism is directly inoculated in the skin. Sporothrix is an example of that, and then I'm going to talk about others as well. So sporothrix is also widespread, exists in two different forms depending on the temperature. So when I do a cytology from a patient, I am looking for a yeast. So it kind of changes shape depending on temperature. And most of the time, the infection is through basically a wound where the organism is inoculated directly into the skin. And it's present in the soil, on prickly bushes, and so people can be infected that way. What do we need to remember about sporothrix? For one, is a zoonotic disease. So I can get that from touching a cat that has draining tracts. So first and foremost, reach for a set of gloves. Two, cats have a large number of organisms in their exudae. This is different from dogs. So the diagnosis of sporothrix in cats is typically not a challenge. If you do your cytology, you'll be able to see this organism. And these cats come to you typically with the history of being treated for an abscess with, let's say, amoxicillin clavulanic acid and not responding. So the thing that will come to mind is like I am dealing with a bacterial infection that is resistant to amoxicillin clavulanic acid, or I'm dealing with something that is not bacterial at all. And sporothrix is a differential diagnosis. Now, dogs are a different story. Dogs are difficult to diagnose. This one had disease for over a year and a half before it came to University of Florida. It used to be a, quote, hunting dog. And as a youngster, apparently had a nodule on his foot, which was removed and promptly disposed. They didn't submit it for culture, histopath, nothing. And then a few months went by, and then it started developing nodules in other parts along his leg. So sporothrix likes to travel through the lymphatics. And then eventually it kind of became a generalized disease. Basically had nodules everywhere. And what they had done, they had basically biopsied this dog multiple times, done cytology, pyogranulometers, no organism, okay? And so it was kind of like, basically came to us saying maybe it's a sterile disease, okay? And I went through the same process. I biopsied this dog a couple of times, and I said, this does not look like a sterile disease, but when you biopsy 3 more times and you cannot get it, get some steroids and cyclosporin, and guess what? We find sporothrix, right? Because basically at this point, we immunosuppressed them and made the diagnosis easier. So the long story short is sporothrix is easy to diagnose in cats, but a challenge to diagnose in dogs because they have very few organisms, okay? So cytology, these are examples of cytology in cats where you see the yeast intracellularly, and then of course, you will see them on your histopath. The treatment is antifungal treatment. You can use itraconazole or iodides. Typically the azoles are the first choice in my experience compared to the iodides. Then you can have other fungal infections. Again, these are all saprophytic organisms that are accidentally inoculated in the skin. Florida being Florida, we see a lot of all this kind of saprophytic fungal infections. I am confident you see them too. And so they get these nodules, they're solitary, and you may find hyphae in your histopath. These organisms typically are hard to kill with antifungals, so if they just have a couple nodules, I encourage you to remove them because that may be all they need. Now, there are some fungi that are pigmented. They're called, the family, the disease is called phaeohyphomycosis, but it's a group of fungal infection. It's not just one. And so again, these are organisms that are inoculated by accident in the skin, sometimes a dirty needle, and then you have these nodules that continue to spread, and they're all pigmented. So that's a feature, that basically you kind of have an index of suspicion. And they may not respond to antifungals, so you have to kind of do a surgical excision in these cases. Other example of saprophytic organism that can be inoculated by accident, zygomycosis. So these are all, I'm just giving you some example of diseases, but the story is basically always the same, that you need to take your biopsy and go for histopath, see that it's fungal, and if it's just one nodule, maybe that's all that needs to be done. If it's multiple, then you may have to do antifungal therapy with the understanding that they may not respond to antifungal therapy, okay? So zygomyces can look clinically similar to pythium. So I'm going to talk about pithiosis because I suppose you have pythium here, yes? I suspect you must have pythium because you have the perfect climate for it. No? You're not aware of pythium? Okay. So I talked about the carrion, and but I want to spend some time talking about pythium. Pseudomycetoma is basically an M. canis that has been inoculated in the dermis. So Persian cats can get these nodules, and it's a manifestation of dermatophytes, okay? But let's talk about pythium. So we get a lot of pythium being Florida, and it's called swamp cancer because it acts like cancer and is characteristic of swampy area where there's a lot of standing water. And here you have torrential rain, so it's a plant parasite. So it's basically when animals get infected with it, it's an accident. It's walking on an area that has pythium in the grass, and then it gets activated by all this rain, and there is basically decaying organic material. For us, it's typical after hurricane season. So this is not a true fungus. It lacks ergosterol. Ergosterol is the main target of the antifungal drugs that we have available. So that makes a challenge to kill pythium. And it spreads rapidly. So you can either get infected drinking the water and you have GI pythium, or you can just get infected cutaneously because you have little cuts on your skin, and then you get in contact with the contaminated water and you get these lesions. And the lesions spread rapidly. They're intensely pruritic. They have this hemorrhagic characteristic. And when you do the cytology, they're full of eosinophils. And if they're spreading rapidly, you have to think of pythium as a differential diagnosis. There is a breed predilection for us. German Shepherds and Golden Retrievers are on top of the list of dogs that get pythium. The key with pythium is to have an early diagnosis. Once you see these lesions that start spreading rapidly, it's not a matter about more cephalexin. You gotta biopsy these dogs and look if you ask for special stains. If you see hyphae, these are GMS stains. So the pathologist is not going to say this is pythium, but it's going to say this is a fungal hyphal organism consistent with oomycetes. And so you need to do aggressive surgical resection. This is why it's called swamp cancer, right? Acts like cancer. We really do not have good drugs to kill pythium, so surgery is the first thing that we need to consider in these cases. If you have a lab that can grow pythium, you can certainly do that to confirm that, or you can do an ELISA to confirm that. But even just a histopath with the history will definitely be very suggestive and consistent with pithiosis. Mortality is very high unless you are very aggressive in surgically resecting these cases. People have tried all kinds of stuff over the years. We do hyperbaric chamber with these cases, and people have used terbinafine and a combination of drugs. But the challenge with pythium is that it doesn't have ergosterol, so it does not respond to the regular antifungal drugs. There is an immunotherapy in the United States for pythium. It's not a vaccine that prevents the infection. It's a way to change the immune response to pythium, because the difference between the animals that come down with pithiosis and the ones that get exposed to pythium and don't get sick is the type of immune response that you build. If you build a cell-mediated response, you are, quote, resistant to it. If you build a humoral response with lots of IgE, you get pithiosis. This is why these dogs have all these eosinophils. So the immunotherapy, and you can order it online. Mendoza is the guy that does that. And basically it's allergen-specific immunotherapy to change the type of immune response against pythium. Lagenidium behaves very much like pythium. And so we have both cases, and I'm sure that you will have these cases as well. So these were the infectious diseases. Now we're moving to sterile conditions. Now, dogs, like I said earlier, can get a sterile nodular pediculitis. So what do they look like clinically? These are typically dogs that come with a history of having on and off systemic signs, not feeling good, running a fever, having, sore joints, maybe being lame. And then they get these nodules, which are truncal, that will rupture, and that will release this oily material. So this is an immune-mediated disease. And so people don't know exactly why some individuals develop this syndrome. Some people have speculated that is some form of hypersensitivity to previous vaccinations, but it's a speculation. In some cases, maybe idiopathic. But the point is that the history is consistent with autoimmune, right, or immune-mediated. It means it has this waxing and waning course, and you are systemically ill, and it's not just about the nodules that rupture. So the suggestion is we always need to think that, okay, am I missing an infection? Because if you do, then you do like the sporothrix case I had, right? That you're gonna make that infection worse. But it might truly be in a dog that this is a sterile disease. So it's a truncal disease. So they get these lesions that kind of drain, and then they may feel a little bit better. Then they may get a secondary infection. But when they start, they are sterile originally. And these dogs require immunomodulation. They require high doses of steroids, many times combined with cyclosporin. So different people use different doses for immunosuppressive therapy, for steroids. But I would say typically ends up being 2 to 4 milligrams per kilogram. And many times, of course, you want to protect their GI. You can start, conservative, and you can combine with cyclosporin. The first 2 weeks, the remission is linked to the steroids, and then eventually you can start tapering the steroids, and the cyclosporin maintains the disease into remission. So that's the true immune-mediated disease. And then another example of a sterile nodular disease in dogs is sterile pyrogranuloma, which I have seen very few of those. And they typically have solitary nodules on the head, and you can kind of like take the biopsy. And once again, I encourage you to rule out infectious diseases first before you jump to the conclusion that it's sterile, because the treatment, it would be immunomodulation. So to summarize all this, I encourage you to kind of, by now it seems I feel like a broken record, right? So you want to start with your segment and your history and your physical exam, the age of onset, how the disease has progressed, the distribution of the lesion, if there is any travel history, so that you collect all this and you kind of think of how you would rank your differential diagnosis. And then start with the basic stuff. Start with the cytology. See what kind of cells you have there. It's easy, it's cheap, it's fast. It can give you a sense of direction. And then many of these cases will end up requiring a biopsy. And the biopsy is both for histopath as well as cultures. And I encourage you to rule out infectious diseases first before you get to the conclusion of considering it sterile. And when you submit your request for culture, if at all possible, I encourage you to ask for minimally aerobic and mycobacterial and fungal. Okay, the anaerobic is optional, but aerobic, mycobacterial, and fungal. And this is what I have.
The pictures looks a lot like the Buruli ulcers in human, which is caused by Mycobacterium ulcerans. And there are studies showing that clay, wet clay, in particular smectite, applied on patch can actually work even better than drugs. So I don't know if you have any experience on that or if you have tried it.
No, I will read into this. Do you happen to know the proposed mechanism for that?
There are different theories. Like one is the mechanical aspect of absorbing and helping the cells, but also the content of iron. There's different theories, but none of them has been exactly proved. But I know it's applied and it works. There's a few NGOs that are using it in remote places, and I think there's also some studies on kaolin, which is another kind of clay, on fungi, antifungal activities. So
yeah, bacterial infection, we use a lot of silver now. That, you know, in the past it was always antibiotics. So I think that we need to have an increased awareness of alternative ways to kill organisms. Thank you.